Hi, I'm Betty Lin-Fisher, consumer columnist and medical reporter for the Akron Beacon Journal and Ohio.com. And I am joined today here by Dr. Stephen Ochs, a urologist with Urology 1 and chair of Mercy Medical Center's Department of Surgery. Thank you so much for joining me here. Dr. Ochs and I collaborated for this month's Healthy Actions column, which ran in Saturday's paper. If you didn't see it, you can get it at www.ohio.com/topics/Betty, and there's a link to all of my Healthy Actions columns, and this one will be here as well as the video afterward. So we won't rehash the whole column. I'm going to talk a little louder because there's some lawn people outside. But we talked a lot about prostate enlargement in the column, and talking about how the prostate, when it's enlarged, closes the opening of the urethra and urine flow. And enlargement itself isn't necessarily a problem, but if the symptoms, which can include more frequent urination all times of the day or at night, or not emptying all the way, is bothering you and your family's lifestyle, then it might be worth discussing with a urologist. And like I said, I don't think we'll go through everything, but if there was anything that you wanted to make sure we touched on with that, we can do that before we move on to...
Yeah, you mentioned that the size of the prostate doesn't correlate with the symptoms.
Right.
And so someone may have a large prostate, but if they're not having any bothersome symptoms, it doesn't cause any problems.
Okay. And so today we're going to talk about prostate cancer. And Dr. Ochs had asked that we focused the column on prostate health and enlarged prostates, and then not confuse it with prostate cancer, just because those are obviously two very different things. And it's hard enough to get men to go to the doctor, let alone probably the urologist. So we didn't want to get things confused. So let's start by talking about probably the things that the men don't like, but prostate cancer screening. And can you talk to me about kind of the different elements of that?
So the first question is who should be screened? And so if you have a family history of prostate cancer, a father, a brother, uncles, definitely should be screened. And usually those people start at age 40. For the general population, we recommend age 50. Prostates are things that only men have, so women don't need to be screened for that, but men over 50 should be screened.
Okay. I think we also talked about how, maybe that was for, didn't you say there were certain races or races that might...
Right. So African American have a higher risk of prostate cancer, so they also, usually we start screening them at age 40. And
okay.
Screening consists of a rectal exam and a blood test.
Okay. Can you talk a little bit about them? I know that sometimes the rectal exam has been a little controversial in whether or not it's helpful.
Right. So most of the time when we detect prostate cancer, we detect it by the PSA number. And so most men aren't afraid of getting a blood test, but they are afraid of having a rectal exam. And so some societies have recommended not doing the rectal exam. We recommend doing both, but if someone's only going to have the blood test, rather you do that than nothing.
Okay, and a blood test is as simple as maybe going to your primary care physician, getting your blood drawn, and in the same test as checking your cholesterol, they can check for that this PSA number.
Right. So the test is called PSA. That stands for prostate specific antigen. So it's a protein that's made by the prostate, and that can be elevated in men with prostate cancer. It can also be elevated in men with prostate enlargement, or if someone has prostate infection. And so we don't like men to have that checked if they're having symptoms of infection, but it's a routine screening test. You can get it done at your primary physician. September is Prostate Cancer Awareness Month, so a lot of hospitals will offer that test free during the month of September.
Okay. And are there any symptoms of prostate cancer?
Prostate cancer has no symptoms, and so when I do diagnose people with prostate cancer, they say, well, how can this be? I feel great. Well, prostate cancer in its early stages has no symptoms, and that's when we want to find it. So a good screening test will identify things long before it has any symptoms.
Okay. And so how then, once you get that PSA, probably, the PSA is the key, right? Once you get that and you have prostate cancer, how is it treated? So,
well, I'll step in between there. So if someone comes into my office and say they have a PSA of 5.
What's the scale?
So that number can go up into the thousands.
Oh, okay.
And when it's up over 50, people usually have cancer, which is spread and is a problem. But we want to find that number when it's less than 10.
Okay.
But most people use the number of 4 as a cutoff for what they would consider normal. So if you've had a PSA test and it came back at 4.5, oftentimes your physician will repeat it. If it's still elevated, then they'll refer you to a urologist. If you do have a PSA of 4.5, anything between 4 and 10, your risk of prostate cancer is about 20 to 25%. So most of the people that have an elevated PSA don't have cancer. The only way to identify cancer or to diagnose it is by a biopsy. But there's other tests that we do to stratify somebody's risk to see if they do need a biopsy. There's a urine test that's available now. And so sometimes if someone comes in, their PSA is high, we'll do this urine test to determine if they do need to progress to a biopsy. So when we do diagnose prostate cancer, 15 years ago, if we diagnosed it in a healthy person, they got treated. No matter how much we found or the grade of the cancer, we were happy that we found it. We'd tell the patient we found it early, then we treat it. And we know that using that as the paradigm for treatment, we overtreated people with prostate cancer. A lot of men diagnosed early will be diagnosed with a cancer which does not grow, doesn't cause a problem. And so most of the people that we diagnose with prostate cancer now are put on active surveillance. So they're not actually treated, but we check their PSA test, the prostate-specific antigen blood test. We check that periodically, and sometimes we'll perform an MRI, sometimes we'll repeat a biopsy. So most people diagnosed with prostate cancer don't require treatment.
So it's very different than a diagnosis of, when you hear that cancer word.
Yes.
Okay.
Exactly.
Okay. And when you say that treatment, what's the treatment?
So the traditional treatments are surgery to remove the prostate or radiation. Radiation comes in two forms. There's a procedure where we implant radioactive seeds. The alternative to that is called external beam radiation. When someone has surgery now, 99% of the time it's performed robotically. It's a form of laparoscopic surgery. So those, I would consider those your standard therapies. Things on the horizon are called focal therapy. Traditionally, when you had prostate cancer, if we diagnosed it in part of the prostate, there was an over 50% chance that we could also find it in another part of the prostate that we may not have seen on our biopsy. Using MRIs to focus biopsies, called a fusion biopsy, can allow us to, with not 100% certainty, but determine that the cancer is in one spot. If we are able to do that, then we can offer people focal therapies. And focal would just mean to ablate either by heating or freezing that spot of the prostate. The benefit of that is that you avoid some of the side effects that radiation or surgery to remove the whole prostate can cause.
And so it sounds like there's a lot of different options there. And so sometimes there may be partial or full removal of the prostate, and you can live without your prostate?
Yes.
Okay.
So the purpose of the prostate is it produces the fluid that acts as the medium to carry sperm for fertility. The problem is that the prostate sits right on top of the muscles that help you control your urine, and the nerves which allow erection run right outside the prostate. And so when we surgically remove the prostate, there's the possibility of injuring those nerves, causing erections. More rarely can it cause incontinence by injuring the muscles which control urine.
Okay. And we'll move back a little bit. We were discussing before about the PSAs, and I think you were saying when we discussed the other day that prostate enlargement is a lot more common than prostate cancer. And so usually when you see that PSA, you'll discuss prostate enlargement or treat for prostate enlargement first.
So if the PSA number comes back at, say, 5, we did a biopsy. If the biopsy comes back normal, then we talk to them about treatment options for enlargement if they had symptoms. But a lot of men won't have symptoms, but the prostate is still enlarged and can cause that number to be elevated. So it can be confusing, but because both prostate enlargement and prostate cancer are common, oftentimes they overlap in the same person.
Sure. Okay. Anything else that we haven't touched on about prostate cancer that you want to make sure we let our readers know?
I think the key to know is that you should be evaluated, you should be screened.
And start with your primary care physician?
Yes.
Okay.
And that's the rectal exam and a blood test. But the controversy in prostate cancer now is not our ability to treat it, because we know we have many good ways of treating it and curing it. The controversy is determining who actually needs treatment. And so prostate cancer is very slow growing. And so if you have someone who is older, even if it's a cancer which we say is one that could grow and cause problems, it may take 15 to 20 years for that to happen. So if someone's 75, the odds are that prostate cancer is not going to harm them in their lifetime.
And the recommendation is the yearly PSA and digital exam?
Yeah,
Okay.
so once a year. And now, if somebody's PSA is really low, some people say check it every other year.
Okay.
But if you check your PSA yearly, and we know this from research studies, is that if you check your PSA and you're screened regularly, you're never going to have a problem from prostate cancer. You may be overtreated potentially, and that's what we're trying to eliminate.
Sure. Okay, sounds good. Thank you very much.